Hello, and welcome to Medicine Today Live. Medicine Today began as a virtual series, and tonight's special live event is part of the 50 years of medicine celebration that allows the Division of Biology the opportunity to highlight Brown faculty engaged in innovative medical research and patient care in areas that are particularly relevant in today's world. I'm Carol Landau, Clinical Professor Emerita in the Department of Psychiatry and Human Behavior and the Department of Medicine. Today, I'm delighted to moderate a conversation with my colleagues, Dr. Jennifer Freeman, and she is Professor of Psychiatry and Human Behavior, and Dr. Nicole Nugent, Associate Professor of Psychiatry and Human Behavior and Associate Professor of Emergency Medicine. Before we get started, for those of you on Zoom, please use the chat function at the bottom of your screen to submit questions during the event. Those joining us in the room will be able to ask questions by standing up, probably. Anyway, we are delighted to be here live. I haven't seen people in a really long time. And we're also delighted to have so many people on Zoom. We're very excited about today. The three of us share experiences spanning decades of psychiatric research and clinical work with children and adolescents. We will each first give an overview of our work. My teaching role first was with psychology and psychiatry residents, and then I transferred over to teaching general internal medicine residents, creating the type of collaboration that's providing excellent care, and that's a topic we'll all be addressing. Also, I've had a clinical practice with older adolescents and adults. I like to write for professionals and for the general public. Now, as I transition to Emerita status, I will be consulting, lecturing, and continuing to write. For many years, I was the chair of the Department of Psychiatry's Clinical Promotions Committee, and I want to acknowledge the growth of DPHB, where I did my psychological residency years ago. At that time, and I'm not exaggerating, we had 2 handfuls of faculty. Now we are almost 500 dedicated clinicians, research scholars, and educators. And as a senior advisor to the Office of Women in Medicine and Science, I'm delighted to showcase the work of Drs. Freeman and Nugent. So Jen, can you go next?
Sure. Thank you so much for having us. Thank you, Carol. Thank you, Alice and Diana, for inviting us. So my name is Jen Freeman. I am a professor in the Department of Psychiatry and Human Behavior. And talking about kind of my research interests in PARC, the Pediatric Anxiety Research Center that I direct are really telling kind of a very similar story. I came to Brown as a clinical psychology resident 25 years ago this July, and stayed to do a postdoctoral fellowship and have never left since, which is really a story that's pretty common in our department and in this community. And PARC really, sorry.
No problem.
Is that better? PARC started, our center started in 1999, right then, as a group of really 3 of us in a small office in the Potter basement at Rhode Island Hospital, squeezed together. One of them was me. One of them was my mentor, my dear mentor, Henrietta Leonard, who some people in this room I know remember. And we started this work together. She unfortunately lost a battle to cancer shortly after that, but really her legacy lives on in everything that I will talk about today. So at that time, our little group was really focused on the assessment and treatment of pediatric OCD, the treatment of pediatric anxiety, and this idea of blending clinical care, research, and training all into one big effort together. And the work we were doing then was primarily an outpatient clinic, a small outpatient clinic treating kids with anxiety and OCD. And luckily, just as time would have it, we got involved in a series of really big clinical trials that were funded by the National Institute of Health and in collaboration with colleagues at the University of Pennsylvania and at Duke University. And these were the first big studies looking at exposure-based CBT for pediatric OCD, which now we kind of take for granted as the primary frontline treatment, but at that time, which makes me feel quite old, we didn't know that, and we didn't have good data to support it. So we did that work over many years. We got to the end of it and had some good research acclaim. We were getting articles published in the Journal of the American Medical Association. We felt very successful. And 60% of kids were getting better with these treatments, and there were 40% of kids that weren't getting better. And we became really interested in who those kids were. And that has really defined kind of the rest of the work that has come since then. There were a lot of barriers to kids getting high quality care. Some of that was just severity. There were kids who were too sick to come to the office. They were too sick to come to Rhode Island Hospital. And we needed something more for those kids. We needed to think about how to bring care to them or bring care into their houses. And I will talk more about that, I hope, later. And some kids had other barriers, systemic barriers. There wasn't transportation. They didn't trust being in an academic medical setting. They weren't being included in these studies. And so there wasn't equitable access to what we were doing either. And so I'm gonna now fast forward 23 years. I will tell you all about the rest of it later if you want to know. And we're now at Bradley. We're a group of 45 plus employees, so no longer 3. And a multidisciplinary team of psychologists, psychiatrists, bachelor's level providers, nurses, social workers, research assistants, all doing work across the same arms that we originally started. So on the clinical side, we have intensive partial hospital programs, 3 partial hospital programs, and a large outpatient clinic. And we provide a lot of team-based care. So bachelor's level providers working with staff psychologists and psychiatrists to do care outside of the hospital. We have a lot of research happening across the translational spectrum, service model delivery, questions around team-based care, telehealth, home-based treatment, translational science on the other end, looking at, how do we augment treatment for kids who are on the severe end still, so magnetic brain stimulation, more kinds of biological interventions. And a lot of work focused on training. How do we increase the number of people that are trained to provide exposure-based treatment in the community, partnering with community mental health services, and how do we keep the quality up? So not just training folks to do this, but how do we make sure they're doing it really well so the access that we're increasing is to high quality care. And we still have, training. We're training all sorts of Brown trainees, med students, residents, quality trainees. And the last pillar that I'll say quickly is just a big value and mission around community engagement. So our group, like I said, is partnering with multiple stakeholders, both within our Brown system as well as in the community to bring care outside of our hospital. We have a big patient and family advisory council that helps us decide the work that we should be doing, and the kind of spotlight of that I will end with here is we have, over the last, 7 years, with a little COVID blip, had an annual reunion, a park family reunion, where we invite everybody that's been part of our program to come back and celebrate at their child's psychiatric hospital, which is not something we know of happening in most any other place, if any other place. And it's just a big day of fun. People come back and we have, face painting and a photo booth and food and music, and it's kind of amazing. And it's one of the things I am most proud of in this whole last 25 years is just watching people flock. Last year we had 200 people come in a pouring rainstorm. And that was because we only could invite those 200. We have 1,000 that have been in our center and have been treated, but we were told there was not room, and because of COVID, it probably wouldn't be a good idea to invite 1,000 kids back and their families. So this coming year is our 10th reunion. I'm thinking perhaps we should invite everybody back. But it's really, it's a pleasure to be here. I really thank my team and our group of collaborative colleagues, and I truly think back to that little office with Henrietta and, in our little Potter basement space that started this really big thing that now exists. So thank you for having me.
Great, thank you. That's so exciting about the reunion.
Yeah, no, we like the
We
reunion.
worry about, stigma and motivation and ongoing care. It's fabulous.
Thank you.
All right, Nicole.
Right. So I'll echo a lot of of the stories that we've already heard, and continue to sing your praises, Jen. So I came here as a postdoctoral fellow back in 2007, and actually Jen was my first clinical supervisor. So it was a pretty amazing training to get here. And then I did my postdoc. I got a grant and was able to stick around. And then a couple of years in, I was invited to get to be part of our pediatric integrated care clinic at Hasbro Children's, the pediatric refugee clinic. And so that I think has been really just my heart space in terms of the clinical work that I've done. So I've done mostly research, but the refugee work in the integrated care clinic is such an amazing opportunity, I think, for all this cross-disciplinary work where literally I'll meet with a family and something comes up and I can run down the hall and grab someone and immediately address both the medical pieces and the psychological pieces. There's no concerns about interpreter services. Families know how to find us. It really is that true medical home in a way that I think I wish we all had. I feel like that is such a humongous, it reduces those barriers to care in ways that I think we really need to have more universally available. I also love about coming here to Brown. I started out, I was doing a lot of work in infectious disease, and so I had a chance to collaborate with my infectious disease colleagues, my pediatricians. You heard that I now am working with a lot of folks in emergency medicine and research on clinical work. And so it's one of the things I adore about being here at Brown is just really, truly the collaborative nature of the faculty, of the interests of the students and the research, this whole community of folks wanting truly to work together and valuing one another disciplines. The other thing that I think, so they've done that sort of that clinical work. I've also done research related to stress and trauma and suicidality, preventing suicide in adolescents, particularly kiddos hospitalized at Bradley Hospital, then also some work out of our emergency department here at Hasbro, really trying to better understand the interplay of biology and social context. And so one of the things that I have been really struck by, I started out as pretty focused on genetics and epigenetics and the hypothalamic pituitary adrenal axis, and I was very bio-focused. And over the course of kind of my experiences with my patients clinically, and also my participants, I realized it's such an obvious thing, but our social worlds are so important. And it became abundantly clear to me that social media is this huge, huge influence on everyday life for all of us, but particularly for teenagers, particularly for folks, even so in college and in residency. And so I think that we are just barely starting to understand what it means to be a digital native, which I am not, but what does it mean to be growing up in a world where your social world involves how quickly you respond to a text message. It really is whether or not you've responded at a certain time and maintained this friendship kind of streak, they call it. And so I'm giving away my lack of digital nativeness right now. But it's these things make a huge impact on the day-to-day lives and the psychological wellness of our kids. So in addition to getting to do some of the work with the pediatric refugee clinic, which I think is really, again, sort of this heart space for me and source of a ton of inspiration for my research, I've also had the opportunity, just in the last couple of years, the Stress, Trauma, and Resilience program has come to fruition, initially as sort of an initiative at Brown, and then now there's T32, which is like a postdoc training grant, and now we also have a co-lead through Leading Hospital that is Laura Stroud and Audrey Turka co-leading that. And those are also these opportunities to continue to extend this research and skills and intervention and training opportunities to the community here in Rhode Island. And so I'm excited to talk with folks today about adolescent mental health, kid mental health, right?
You see, we have in common, we came, we got educated, we stayed. So now we're going to talk about some introductory issues and questions first. And the first question was, is the crisis in adolescent and child mental health a result of the pandemic? What is this crisis? So Surgeon General Vivek Murthy has stated this: adolescent mental health is the defining public health crisis of our time. Mental health is the fuel that allows us to show up for our communities, our friends, our families, and lives. And when that fuel is low, it compromises our ability to be who we can be in our best moments. And I have to say I'm heartened that the Surgeon General is taking this stand. This, however, came out after the pandemic, but we know that the crisis actually preceded the pandemic. When I wrote a book on this topic, I was doing research in 2018. And at that time, we knew that anxiety and depression are the most common psychological diagnoses among children and teens. But the troubling data was significant. Half of all mental health conditions start before the age of 14. And at that time, the single point prevalence of a major depressive episode, not just symptoms, was 13% overall, which was up from 8% in 2007, and a whopping 36.1% amongst adolescent girls. Higher rates were found among Native Americans, those identifying as multiracial, and of course, LGBTQI people. Among the teens, 32% were experiencing one of the anxiety disorders. And this is a larger category we can go into, part of which, of course, is OCD. Again, with higher prevalence among girls. Suicidal attempts were high. Suicide is the second leading cause of death for teenagers, especially those aged 10 to 14. Recently, it's become the third cause of death because in the ages 15 to 19, homicide is second to accidents, which is the first. LGBTQI teens were 3 times more likely to commit suicide. ER visits for self-harm rose by 329% between 2007 and 2016. And interesting that we're talking about social media because it is implicated in a lot of the problems in mental health. But something else happened in 2012 when things started to escalate even more. And I must say I was kind of horrified, but I'm glad I was awakened to this point. After Sandy Hook, there was a cultural shift in our schools, which includes active shooter drills, lockdowns, and by 2016, they occurred in 95% of high school and primary schools, with safety measures, metal detectors, cameras, locked doors, etc. And of course, at the same time, student reports of fear and anxiety went up, as did their feeling less safe. So that's the backdrop. Then came COVID. Well, COVID made everything worse. There was a critical article in JAMA Pediatrics 2021 that reported that symptoms of anxiety and depression globally, not just in the US, had doubled during the pandemic. I won't drill down too much because I think we all know what happened. And I think one of Nicole's point is that we need social fuel. We need it. Teenagers definitely need it. Take their social fuel away from them. They're at home, which is variable. They're not being educated. They don't have access necessarily to their friends. And again, the Trevor Project reported that LGBTQI students felt, 42% of them felt they were seriously contemplating suicide because of social isolation and lack of access to accepting adults. Interestingly, we should also remember that 200,000 children lost their parents or grandparents during the pandemic. So we have all these factors affecting them. I also want to mention that the entire country had a lack of surge capacity. So our stress expert here can tell us that when an emergency happens, we're ready to go, we're ready to take care of things. 2 years later, it's another story. Everybody probably is still exhausted, and certainly families were. And a study from Yale found very early on that mothers at home or working from home experienced greater levels of anxiety and depressed mood and did fathers. I don't think we're surprised, but of course, fathers at home who were alone were similar. Worldwide, women experienced almost 3 times more, were more likely to have a mental health problem during COVID than men. I'm just going to mention post-COVID briefly because we can move on. By 2021, more than 4 in 10 students felt persistently sad or hopeless, and nearly 1/3 experienced poor mental health. The study at the University of Michigan has a little bit of good news, but the bad news was again that if they had record levels of anxiety and depression in a study of over 100,000 students. The good news was that 37% of them were in treatment, so that's pretty high compared to previous times. So now we'll go back to our guest and talk about what effect did the pandemic, if it did, have on your work, and have you studied it, and how has it looked to you?
Maybe I'll start because I have a segue.
Okay.
That maybe will set you up for some of your work. So I definitely saw that it impacted the refugee community for sure. In the very beginning, in some ways, some of the kids told me that they were grateful to not be bullied anymore, that there were actually some benefits to being remote, but those benefits went away pretty quickly, especially as time came to return to school and so many kids didn't, so many kids missed school. And the ways that I do therapy had to change immediately because what used to be in person in the clinic, removing barriers, which is great. The good news is that we could have phone calls or we could do video, which removed the barriers, but there was no privacy. So I couldn't have a conversation and, I never knew who was waiting in the other room or listening in. People were coming and going. Benefits to that, of course, are that you now see someone's life in a way that you don't see that in the clinic. So I think there's pros and cons for sure. And since returning, I still see a number of my families remotely and some of them in person. It's really nice to have that flexibility. But I did have one kiddo who came in, who sort of had self-identified that he had OCD and that he was really struggling with that. And it had been a while since I had really truly done the OCD treatment intervention. So I got a hold of Jen, of course, and said, "Oh, what do I do? Is it different now?" Again, this is, I think, one of the benefits of being at such a collaborative academic medical center is that we can, I can't be an expert in all possible things. And so in these moments, I can grab you and say, "Hey, what should I do?" And the good news is that it hadn't drastically changed. You had some updates for me and some suggestions. And I was really in awe of how smoothly the intervention actually went. The fact that he could be in his actual home, that the places where he might have normally washed his hands and needed to repeat it a certain number of times, it's just, you can't replicate that in quite the same way in my office in the way that you can in your home, that you're living in day in and day out. And so it was really, so I will say, and this is sort of just a theme I like to come back to, I do think things are harder. I do think things are worse. I do think there are spaces that we can still keep getting hope, we can still keep expanding, where we can take the lessons that we've learned before the pandemic or that we're continuing to learn through the pandemic to create ways that things can continue to get better. So since I brought up OCD, I want to...
That's a good segue. I agree that things feel worse and harder. They were really bad before COVID. We used to remark about our long wait lists, really long wait lists to get outpatient treatment. That is something that has been an issue for years and years. Our own research outpatient study wait list, I think pre-COVID was in the 50s, and that was pretty bad. Waiting, 3 to 6 months to get treatment. And now that wait list is well over 100 on most days. So that's different. Kids, that doubling of anxiety and depression is real. We really see that. And the interesting thing from an anxiety perspective, sort of twofold. Some kids, and Nicole, you sort of said this, like had a reprieve, are really socially anxious kids. Kids who were really fearful of, being out of their house, out of their safe zone, all of a sudden didn't have to go to school. They didn't have to go to birthday parties. They didn't have to go to sports. They didn't have to, and there are complicated intersections of not wanting to go to school because you're being bullied or for other reasons as well. All of that went away. And so we had a group of kids that for a while were like, hey, this is great. Not just because they weren't doing school, but because they weren't triggered from an anxiety standpoint. And we actually had to sort of think hard about, we had this whole group of kids we were treating. And again, treating with these models where we're trying to treat anxiety where it lives, to send people out in the world. Again, our bachelor's level providers that work in tandem with our doctors, to send them out and treat real life, anxiety, to help walk into school, to help leave the shower if you're having trouble, to separate from your parent if you can't, get out of the car. And a lot of that didn't need to happen anymore. And we were like, well, we don't have anything to treat. And a lot of kids weirdly had to get discharged from our care because we didn't have a target, which made no sense because they were really quite anxious. And so if you now look at that group of kids today, they're struggling even more than they were before. So they were sort of making some progress, and now they have to kind of go back to square one. So to your point, we also had to pivot all of our research studies. We had this large PCORI-funded study that we're still finishing that was testing office-based care versus a team-based model of care where, again, the primary work is happening in the home. We had to switch all of that to telehealth. And that was really defeating the purpose of what had been sold as a home-based study. And so we luckily got some supplementary funding to test a telehealth model of our team-based treatment. So bachelor's level providers doing that care, and also the psychologist seeing the patient once a month. And the good news there is, so the bad news is we weren't leaving our offices. We weren't getting to go and actually help kids in their real life environments, which I still swear by. But we got some good preliminary data about whether that worked, and it actually worked really well. And it worked quite equivalently to seeing a psychologist once a week in the office via telehealth. And so what that tells us is, or it leads us to interesting questions. We have a grant that we're waiting to hear about any day that will compare a telehealth team-based model to an in-person team-based model, because we think there may be differences in access. And so on the one hand, going out into people's homes feels like getting at anxiety where it lives and OCD where it lives. But for some families, home isn't a place where you want, your therapist coming or your clinical provider. There's not enough room, there's not enough space, there's not enough privacy, there are other dangers, there's other triggers. And so thinking about balancing, sort of the reality of, are there places where telehealth might work better and places where in-person might work better? And quite honestly, the third arm of this study is a hybrid, mixing both, just like we are doing here today, because that's become the reality of our world, and having a more kind of patient and clinician-driven way of thinking about how do you make choices about whether it makes sense to do an in-person visit or do a remote visit. But with these team-based models, or task sharing as it's called, the other key thing we've learned during COVID, pre-COVID, but especially post-COVID, is that we have this terrible access problem. We don't have a big enough workforce to treat all of the kids that need mental health treatment. And so by combining, the kinds of providers we're able to utilize in highly, highly trained ways, we can expand the workforce. We can expand the diversity of who can be part of the mental health workforce using community health workers, for example. So there are a lot of opportunities through the current research that we're involved in to expand the footprint and sort of treat more kids and also treat them in different ways. So that's kind of the way that we're attacking it as a group. But it's been interesting, like anxiety is interesting in that there were parts of that isolation that made kids look better-ish for a while.
And challenging when they had to go back.
Yeah.
Right. We've got a big question here probably for all of us. Can you speak to some of the different reasons our kids are anxious? Social, environmental, traumatic, genetic, and so on. We were brainstorming about this. We probably could go on forever, but we'll probably just hit a few for you.
I mean, I will say all of the above. There is no one answer. Anxiety, speaking about anxiety in particular, and OCD especially, there's definitely a genetic component, to OCD even more so. But having, anxious parents and anxious first degree family members does not mean you're going to have anxiety or OCD, and you can certainly have anxiety or OCD if your family members do not have that. So it's not just genetic. There are lots of social and environmental stressors, and we know anxiety is also stress sensitive. So kids, often we see there might be a genetic predisposition, but then there's some other stressor, be it a full-scale trauma in their life in the case of too many kids, but also just other life stress. COVID being an example of life stress, interpersonal stress, relationship stress, school stress, pressure, social media stress, which I will let them talk about. So it really is this multifactorial, sort of jumble. The thing that I think is important to think about is, and it doesn't necessarily change our treatment, but feels important from a kind of, causal standpoint, is also thinking about what's real life stress, what are these real life challenges that someone really needs to be worried about, and versus kind of excessive anxiety that may be more, and that's those things aren't necessarily mutually exclusive, but that sometimes helps us think about some of our treatments. We're all most everybody, not every single person, most everybody's anxious in some way. It's kind of protective. It's okay to be anxious. And our work is really teaching kids and families that you can be anxious and live your life, as opposed to be anxious and to avoid lots of things. Like we really, preach feeling your feelings, and feeling anxiety is one of them, and that's fine. But you have to be able to, you have to be able to sort of do all of the things you need to do at the same time. And that's where we keep going back to exposure-based treatment. Lots of families come to us and say, nobody ever told us that this was the right treatment. Nobody ever told us exposure was the right treatment for our child's anxiety or for their OCD. And we've wasted all these years. All these years where they didn't get the right treatment, and now you have this treatment, and the good news is it really works. And especially if we can sort of change up how we deliver it. So we want that
also
message.
Goes against some parents' protective qualities with an anxious.
Oh yes,
person, but
100%.
Right.
Yeah. So part of it is, saying this is the right treatment, and part of it is convincing parents why you should do the hard thing. And that's tough. I get it. Like, I'm a parent. I say this to families all the time. Like, I get it. It is not like in our parental instinct to make your kid do the hard thing, and that is exactly what you need to do. Gradually, slowly, thoughtfully. It's not fear factor, everyone. Like, we're not putting people in vats of bugs, but we do have bugs, and we practice that, and that's really important. So, and that is, I'm sure, what we talked about 100 years ago. So that's my quick answer.
Nicole, do you have other factors to add? Do you think that's causing the crisis?
Yeah, I think I would love to talk some more of the trauma piece. I do want to just reiterate that part that you said about we both alluded to about the parent piece.
Yeah.
And one of the things that was for me early in my training when I was a postdoc and I was part of the POTS Junior protocol, which is this exposure protocol. I found in more than one family, we would start. Often parents were disagreeing. There was all kinds of conflict. Mom or dad was struggling with depression or anxiety. There were all kinds of these challenges the family was facing. we said, we're gonna focus on your kid right now. We're just gonna do this protocol. We're gonna, be honest about the other things that are going on, but really, it was amazing to watch how frequently, to a case, and I didn't have as many cases as you had, but to a case, every single kid got better. Every single parent who'd been struggling with their own stuff got better. Some of that was just the like relief of I don't have to constantly be unsure about how to help my kid. Some of that I think was that they realized that there was stuff that they could do for themselves that they never would have done for themselves, but they did it because they were doing it for their kid. I think it was really amazing to watch how you can help a kid and actually you're helping the whole family system. Everybody's hung along with them and improving. So, and just to piggyback also on that piece of hope. So in trauma work, it again, so common. The kids, the parents will tell me, first of all, maybe that nobody ever asked. And so, or if the kid did disclose it, nobody did anything. So the kid thought, oh, this is not important, or it's not a big deal, or we shouldn't do anything about it. And so when kids finally, someone asks the question, takes it seriously, and then when they get into appropriate treatment, we know it works. I mean, what is so cool, when I first started doing trauma work, it was all assessments. I wasn't actually doing therapy. And it was horrible. I would have nightmares. I would get so upset. And then as soon as I started getting to finally do the treatments that we know work, like trauma-focused cognitive behavioral therapy, it was like I could sit there, I could be present, I could bear witness, but I could do that because I knew this was just part of the story. We're going to get you to the next part. It's going to be okay. It's going to get better. And so I think that's the thing that, I hope, again, like coming back to that piece of it, but also coming back to that piece of the trauma. I mean, in the field of traumatic stress, we've sort of tried to tease out this question of, like, is it genetics? Is it environment? And of course, you have to be exposed to trauma. So to some degree, we assume that there's a trauma, there's an environmental piece. But when you start increasing the number of traumas that someone has experienced, it pretty much everyone develops PTSD. I mean, you just can't face hit after hit after hit. Mm-hmm. The other thing that the field has, particularly during the pandemic, particularly in response to really heartbreaking videos that make it so clear that Black Lives Matter and that we all need to be thinking about what is happening in our world in ways that we didn't notice before, or that not everyone noticed. But that we used to think a trauma had happened to me. I had to personally be attacked, I had to personally maybe witness something, and increasingly we've come to realize, I think, as a field, that you can very personally be impacted by something you see on your cell phone, on your TV, on your computer. And so I think the other thing that we're starting to realize is just how much we've all been hit time and time and time again with trauma that really is that is genuinely traumatic in ways that we used to think, oh, these don't sort of count as a PTSD kind of thing. So yeah, I mean, I think that seems like I keep telling you guys I'm gonna end on hopeful moments, so I will later.
You can.
But we'll stop for the moment because I know there's lots more questions.
People who stay in this field are optimists. That's how they do it. Just a couple other factors that we haven't covered, and they relate to a couple other questions. Certainly Black Lives Matter, but gun violence in general, and the kind of overall culture of anger and attacks on women's reproductive health. And families are affected by this, and so kids are affected by this. And the last thing I wanted to mention too that we haven't gotten to, and we have experts at Brown about this as well, is sleep disruption in teens. It's a big problem, and the more they're on the phones, the less they sleep. So that's made it worse as well. Another question, I think we may have covered most of it, but how do you determine which treatments work best for different people and different disorders? Now, exposure for anxiety, trauma-based informed CBT, any other categories of folks we should be thinking of?
I mean, in work with adolescents, dialectical behavioral therapy is so helpful.
And
Often, yeah, and fun. So often, even when I am doing something like TFCBT or another empirically supported evidence-based treatment, I still build in some of the DBT skills because they're so effective and they're so well matched to that stage of our lives. Of how do you be successful in your interpersonal relationships? How do you manage your emotions? How do you identify your emotions? How can you be successful in your life?
I totally agree. We use a lot of DBT in line with our sort of adjunctively with exposure-based treatment. One of the things that I think is important and sort of goes with the values of our center, though, is also thinking about training. Lots of folks know exposure therapy is the right thing for anxiety, but are really fearful to do it. So even, clinicians, in the community who've had some training, the rates of use of exposure are incredibly low without ongoing support. And it's because of that fear of I don't want to make someone anxious and then not know what to do, or I don't really know how to do it. And so a lot of our work for that reason has been focused on dissemination and training, and how do you do not just a one-time training, but provide consultation and support so that someone will really use this service or use this treatment and use it in a high quality way. The other piece that I think of when I think of sort of matching is that even though we know exposure broadly fits for all anxiety and OCD, it actually matters a lot in terms of thinking about the function of someone's anxiety or the function of their behavior, kind of in a behavioral analysis way. We think a lot about what is it that someone is avoiding, what is it that's causing anxiety, so that we know how to do exposure. And so the example I give a lot that's quick is somebody might be avoiding, let's say you have an elementary school student who's avoiding walking into the school building, and everyone says, oh, they're anxious about going to school, we have to practice going to school. That doesn't actually tell me why they're anxious. If I just know that they're not going into school, they might not be going to school because they're afraid of separating from their parent or their caregiver. Then we have to practice separating. We don't actually have to just practice going into school. They might have a contamination concern, like an OCD concern. Then we have to practice being in contact with that contaminant. That again might not be specific to school. They could have generalized anxiety and be really worried about their performance or getting good grades, or do they know what the answer is on the test? That's a little more school relevant. They could have sensory concerns and be worried about noises in the school, loud noises. They could be being bullied. That might not have anything to do, that might be making you anxious, but not necessarily in a way that exposure would be the right treatment. So that's not even all of the things I can think of, but it's a really good reminder of it's not just knowing that exposure is the right treatment, even you really have to drill down a little to understand what's happening in the context of this, kid's life.
Let's take one more of the introductory questions, and then we'll be encouraging people here and people on Zoom to submit questions. This one's about collaboration. It has several parts. Can you talk a little about how collaboration plays out at Brown? We've heard a lot already. How some of the research coming out, what's it been like for you? And then there's also comments on talking about working with primary care physicians and students.
I'll try to go fast. I'm not very good at that, apparently. We've talked about it a lot already. Collaboration is really important across sort of all layers of what we do. So in our center, the reason I have stayed here for 25 years is my colleagues and the ability to do team science with a group of other people that I work with who all care about the same thing, but we all do it kind of differently. So there's collaboration sort of within our small group at Bradley. There's collaboration in our department, which allows me to continue to work with wonderful people like Nicole. So our group at the moment is collaborating with the School of Public Health around some of these policy implications of, getting team-based treatment out in the world and collaborating with community mental health centers. That's another level of collaboration, like collaborating with our own community, engaging with our own community. We have other collaborative efforts with computer science, so some of the kind of technological sort of advanced technology versions of treatment that are happening in our group involve using virtual reality to train therapists. So we need to partner with computer scientists using artificial intelligence to help us think about ways to code what's happening in sessions, again, to look for quality. And that's sort of an innovative use of AI. That's my area. And, coupling with other parts of the faculty to, look at neuromodulation and brain stimulation and those pieces. So really kind of across that range from community engagement and public health all the way to much more biological neuroscience kinds of collaboration. So I just feel that I tell people who are interviewing here that I do really believe that that's something special about this environment, special about our med school. Like that works really well here, and that stands out.
So I've talked a little bit already about the pediatric refugee clinic. So you all know that I adore working with my pediatrician colleagues. I can't imagine doing that work without them. But I'll sort of shift a little bit away from that to talk also about how that's led to some other amazing collaborations with students, to your point, and with other parts of the system. So in around 2015, 2016, I started getting involved through the work that I was doing in the pediatric refugee clinic with the Brown Refugee Tutoring and Enrichment Program. And so I had this chance to work with these amazing Brown students who go into the families' homes and teach all of our refugee kids. They teach them English, and they're help them with academics, but the kids, I think, and the tutors get so much more out of it than just that part of things. And so it's been really amazing to get to work with the students, with the bright students, and just see the impact, the real impact that the kids, that the students are having on our kids and vice versa. And so that has been incredible. It's been incredible. I teach a summer studies class, a summer at Brown class. And it's on the psychology of resilience. And, we have these conversations that are really, truly bi-directional. I've learned so much from my students. I didn't know about social media streaking until they told me about it. Like, I was like, what is this thing? It's for people who don't know, because I've mentioned it now twice. What it is that you're on, like, let's say Snapchat or something, and you have like a friend, and in order for you to maintain your friendship streak, you have to interact with them every day. Am I getting this wrong? People who actually know. Okay. This is like, okay. So I mean, I've learned so much from the students who think that they're learning from me, but I'm really learning so much from them. I even was sharing this story before when we were talking about this meeting today, that one of my students from summer at Brown, I guess it was like 5 or 6 years ago, she was like, I really want to come to Brown. She came to Brown. She's a research volunteer in my lab. But it's kind of crazy to kind of see people through that journey. So I've learned a ton from them. I've worked also to again, relate to social media piece. It became so clear to me that the social world for increasingly so many of all of us, is really through your phone. It's through texting. It's through messaging and Instagram. And so I reached out to a colleague, just believe me, this could never happen, I think, at any other institution. And just emailed this guy in computer science, and he hadn't even unpacked his things, and he agreed to do research with me. And so he's, worked to develop this way of pulling down de-identified social media without any video, without pictures, things like that. But just to try with people who are, research participants, to sort of talk with them, to sort of sort out how it is that their social worlds are impacting them through social media, not just the voices. I've worked with folks in, like I said, I've already kind of outlined all the different departments. I won't repeat that here, but it is really the best science, the best clinical work comes when we work together across disciplines, and to your point, across different areas of training, different levels of training. I think that is how we can start to chip away at the incredible disconnect between how much need there is and what our system currently has available.
Just from a training point of view, I've been fortunate to work with general internal medicine, where we have, I will brag for a moment, produced several hundred primary care physicians, many of whom have stayed in Rhode Island despite our low reimbursement rates. And our training, Colin Harrington and myself and a lot of GIM people provide a curriculum of 3 years that focuses on psychology, psychiatry, development, as well as self-care. And so that's just been a real joy for me, is to collaborate with those folks. I want to turn it over to one of our admin people, Diana Richardson, to tell us what's happening.
Yeah, we've got some questions coming in online, so I can get us going with one.
Okay, great.
We have somebody tuning in whose daughter actually thrived in the Bradley program, but is now in college and her anxiety is starting to take over again. So this parent is looking for some advice on sort of what to do once you've outgrown Bradley and what kind of treatment and is available for older children.
It's a great question, and probably one that we can all answer in different ways. I think there were other questions that had been submitted ahead of time about, how do we best assist college age youth in getting mental health treatment. And I am the parent of 2 college age youth, and it is a hard age because they are both adults and not adults. And there are, I always say first for, to try to see what's available on campus, what kinds of mental health services are available if they're at a college through that college or university. Colleges and universities often also have referrals in that general community, that are specific to given problem areas. It's always fine to reach back out to Bradley, to a clinician from the past, to get advice about, in this particular place, where should I look? The treatment is the same. Exposure-based CBT is still the right treatment for anxiety. If you're a kid or you're an adult, you might want to add different things. There might be other pieces to it, or depression much more commonly comes online as anxious kids get older, especially if they're still struggling with anxiety. So it's not an easy question without knowing the details, but there are lots of resources. I also submitted as some of the websites for folks to have some of the national organizations that list providers by state. So the International OCD Foundation, the Anxiety Disorders and Association of America, Anxiety and Depression Association of America. There are provider directories where people, say I'm in X state and I am credentialed to do this kind of treatment. So I think that can be helpful. Of course, the waitlist problem is always going to be a problem, but that's my quick answer. You're
Yeah, I
a
think,
college expert too.
I'll just add, Psychology Today has a very good reference list where you can drop down. I see some colleagues in the audience, and so I'm reminded that college psychological services are overwhelmed too, but I think they're doing as good a job as they can, both directly and also by collaborating with physicians and working together. But I think all those ideas, go back to your original therapist, look for the type of treatment that's worked for you, and also use some of these referral services.
Telehealth, so the good news about telehealth, and sort of virtual appointments is that in some ways and in some places that makes it easier and can increase, access. But there are lots of rules, especially now, post-official pandemic, about licensing. And so crossing states and, so I can't necessarily continue to see someone virtually who's in another state where I'm not licensed, who's gone to college someplace else. And that seems really confusing for kids and families, because they're like, you could see me if I'm in Rhode Island on a computer, but not somewhere else. And so there are system level policy changes to try to, make more national licensing agreements to allow us to be able to do that, but that's not something that's possible now.
I think we should take a question from the audience, if anyone. Adam,
You have a few of you and lots of people who need help. And so much of the thought process that I feel like I'm hearing is one-on-one with many visits, and just can't fit it all together. Do you have thoughts about how treatment can be more than one-on-one, and obviously there are models for group therapy, but I just don't know what's effective in that, what your experience in that realm might really recommend.
Thank you. I know you sort of alluded to some of the capitalizing on local, folks who don't have, let's say, an advanced degree, and on teams. One of the things that I was really struck by, some of my kids after the pandemic, some of my kids started coming back and teaching me some new skills they were learning about deep breathing and all these different skills. And a lot of what happened during the pandemic was that the schools recognized that the kids were incredibly stressed out and that they were really struggling. And so what we saw was a little bit of this happened during the pandemic, but for sure when kids started coming back, that there were a lot of efforts in place to try to provide basic coping skills for all of the kids. That's not enough for many kids. So for some kids, I think that and sort of like low level of just skill provision and knowledge is really helpful. I think that in general, this next generation, they're much more open to mental health in a way that former generations have not been. And so I think that helps as well because they know what to ask for at school. But I think that it's still not enough. I think that within computer science, for example, there have been a lot of efforts to try to broaden access by using, online tools and these apps. What's tricky is that most of them have not been tested, and who is monitoring them? So I've definitely, in my research, seen examples where kids are texting with a helpline and the helpline person is not being helpful. And so, it's tricky because I worry sometimes. On the one hand, I think it's really important for us to make sure that care is available to everyone. And you can't do that if you're expecting, like you said, one-on-one therapy with somebody who's highly trained. And also, it's tricky. A self-help book, you don't think somebody's on the other side, knowledgeable, giving you feedback in the same way that you might feel it in, a text in a help call. Yeah.
So I have two questions. It's really interesting. I just got this message about this lecture and it sounded interesting. How you're talking about psychotherapy and these CBT's cognitive behavioral therapy and all these things, because I see patients, I'm an allergist, but I have so many patients that are on antidepressants, and so many of my patients are anxiety. And what I find that a lot of the internists in primary care, and then I have a second question, everybody's put on meds, and even with OCD, they're put on meds, and there's no mention of any psychotherapy. And so I'm glad to hear that that's available to people, but it seems that they're all coming to me. I mean, so many college students who come to me, they're all on antidepressants, anti-anxiety meds, and no mention of, and it seems like the psychiatrists are focusing on medicines. So that trend is changing, I take it. And then on OCD, there is a psychotherapy, and it's not just medicines, because I don't want to sound naive, but that's all that seems to be that's happening to a lot of patients.
That's a great bit of reality for us. Thank you.
And
I want to answer that other question, and I want to answer this question.
my answer is the effects of marijuana on all of this too.
Oh, wow.
Because that's something that seems to be, I can't tell you how many patients are doing that. I mean, it's legal now, but when it was just medical, and that's being combined with all these meds. So these are my questions to you.
Those are all really good questions. I just want to go back to the unable to treat everyone very quickly, and we can talk more about it afterwards. But again, it still doesn't treat everybody, but these models of task sharing that have been developed in countries where there are truly no mental health professionals at all. So training folks, again, people without bachelor's degrees to work together with a master's level licensed clinician, that's the work that we're trying to expand to just grow the workforce. We have to grow the workforce of people that can provide high quality mental health care. In our current study, which pairs a PhD level psychologist with a bachelor's level provider, we can double the footprint of a psychologist by using this model, and the outcomes using what we've been doing have stayed exactly the same, if not been better, than our original tightly controlled RCTs. We've just started peeking at that data. 70% or more of kids getting better using that model. So we're really hopeful that like that piece can, again, it's not perfect, but that will definitely allow us to treat more kids. And then if we scale high quality training and bring that outside of academic medical settings, again, that will further increase the numbers of kids that have access to truly high quality care. It's not happening yet. There are wonderful treatments for OCD and anxiety that don't involve medicine. So exposure-based cognitive behavioral therapy is the right treatment for all anxiety and OCD.
And what is exposure based for someone?
Facing your fears for a really, I'm happy to talk much more about it because I know we have no time. I'll answer more questions about exposure afterwards.
Diana, can we take about 5 minutes more? Sure. I think in some cases with physicians, it's a lack of training. They know how to write. In fact, I think Peter Kramer said that when they were creating Prozac, that the people in the pharmaceutical company said, so easy that an internist can write the prescription, which of course was nasty. But I think these drugs, which are very helpful to people have forgotten the other side, which is most people agree both is better. But I think the other piece is that we're forgetting about all the people who don't have access to anything. And I think we've got to have some structural changes in society, like Medicare for all. We have to embed psychotherapy ideas and people into school systems. School is where they are. That's where the help should be. And we're creating models, I know, all over the country, but we just have to do things like that if there's any hope for equity at all. Anybody else online? Okay, well, we have one more here, if anybody else.
While you're pulling that up,
Yeah.
myself and Leslie Brick have a recently NIH-funded study to look at cannabis use after a trauma. So stay tuned. 5 years from now, I'll have this.
Has EMDR been part of the behavior-based therapies, and has it been used for OCD, or how successful has it been?
That's a great question. It hasn't been used in our center with OCD or anxiety, and there's some data that is mixed historically. I haven't looked at the EMDR data recently. I feel like it's been used more in PTSD, but it's not. Parts of it actually are consistent with exposure, so I sort of think of some of that as being very much like doing the exposure piece, but the specific eye movement retraining piece, there's been less data to support, but again, not my area of expertise.
And I think that everyone will have a list of some recommended websites to see
Right, and
updated
resources.
information.
Yep.
And the International Society for Traumatic Stress Studies does every couple of years this very thorough job of identifying what are the levels of recommendation and evidence for different interventions. And so EMDR is an example of something that has had enough support that it seems like it works. To Jen's point, many researchers have felt like it could even just be lumped in with those other cognitive behavioral therapies, because there really is CBTs happening along the way, and it also involves exposure. So EMDR, for folks who don't know, involves the idea of think of your trauma, which is inherently is exposure. And so I think for anyone at any time, you might 5 years from now find yourself wondering, what about this intervention, or this new thing happened in the world. We're going to give you guys a list of resources. For me, the National Child Traumatic Stress Network is the go-to place every time, sadly, a new shooting happens, a new horrible thing in the world. I know that I'll go there and they'll provide the most up-to-date information. They'll provide it in multiple languages. Unfortunately, not all of the languages that I need, but in many. And a ton of resources. So again, what I'm going to say right now, will be differently, you might find 5 years from now that you're wondering something, you can't remember something, or you want to know that state information. And so that's a good place to look.
Okay, we'll take one more question, then we have our closing questions, and we invite all of you here after this to join us in the Rhode Island Medical Imaging Commons area on the 3rd floor. But I like this question as a final question before I ask you guys what you want for your programs. And that is, what's one thing that we can do to instill resilience in our teens?
So I'd like for us to be consistent. So I'm gonna go ahead and be consistent. And we talked about this idea of how, for example, at Park, a big part of treatment is approaching things that are scary. And so I think part of how we build resilience in our children, part of how we build resilience in ourselves, is to identify where are those areas of growth, push those boundaries. We're not talking unsafe, so we don't want to make somebody unsafe. But, you know, if you are somebody who likes nature, push yourself a little bit, go on a hike, a safe hike, go on a hike. You know, there are lots of ways that we can teach people, we can teach our kids, we can teach ourselves, all kinds of skills that help us to be resilient moving forward. You know, there's also just a ton of really great resources out there. You can think of, personally when I teach my summer studies class, I teach from a couple of books that you could buy off the shelf right now. There's one called The Psychology of Resilience, that's my favorite. But they break it down into these like very basic things. And, you know, pushing yourself is one of them. When I teach my summer studies class, I teach them 3 things. One is avoidance is bad, social support is good, and I want them to know the outcomes of the hypothalamic pituitary adrenal axis because they can't let go of that biology. But really, again, like this idea that the same things we've already talked about here already around what helps us be resilient.
I will echo all of that. The way we talk about it with younger kids in our clinic is bravery practice. We teach kids how to be brave in contexts and situations where it's safe to be brave. Of course, that is always the caveat. But you asked about, you know, what exposure is. Exposure is bravery practice. And the younger you start that, the more likely you're going to end up with, you know, I hope, again, lots of stressors, notwithstanding, a more resilient older kid, teen, and hopefully young adult and then adult.
I want to echo the social support thing, because I don't think we've talked about it enough. If you have one person you can confide in, especially when you're a child in an adverse circumstances, one safe person, and that can go through life in terms of support, connection, problem solving. I think that's really something we should also do, and also family members, we can't forget that. Okay, what's next for the Park and the STAR initiatives?
For Park, we want to keep doing what we're doing and grow it. We want to keep growing these service development models. We want to keep using new technology, novel technologies, and optimize treatments with some of these biological tools that we now have at hand. And we want to keep doing, you know, we want to grow our clinical programs because there's clearly a need. We want to grow our training programs and keep our community engagement efforts. So keep working with all of the stakeholders that are both ground-based and community-based, and also, you know, think about how to expand that beyond that nationally, and to keep having our reunion. But that's different than the next question. That's not what we need. That's what we're doing. I'm really excited about what we need.
It'd be a nice place for your reunion.
Yes.
So for STAR, you know, I think we have a really great, the researchers involved are have a nice foundation of research. Always there's more work to be done, important work to be done. So I would say that it's gonna hopefully, you know, undoubtedly will persist. We're still pretty nascent, and so continuing to build those relationships with our community, building out our clinical piece of our work. A lot of it so far has really been focused on more of the research piece and the training piece, and I think there's so much need when it comes to addressing trauma. and stress. So I think building those pieces out will be really helpful. Yeah, I mean, I do think there's a lot of hope ahead for both.
So, more faculty, more funds for outreach, community engagement, building your programs. And for all of you out there who may be mental health professionals, I know we've talked a lot about the trials and tribulations of this, but back to the social support, I don't think there's anything better than being in a great therapeutic relationship from either side. And so I think we have to remember how much a privilege it is to work with teenagers and with kids to help them get better, and also because it's really a lot of fun most of the time. So for those of you online, this is going to be resources will be sent out. We're also going to have a video of this event, and we hope to all see you at the reception. Thank you.